Okay, welcome everyone to our bi-monthly mechanical circulatory support meeting, which we do virtually. I just want to remind everyone quickly about the basics. Please scan the QR code that you see currently on the first page. This will give you CME credit. We will also be placing the link in the chat box. We would love your participation. As always, today is a special talk as well, but we would always love your participation. Please add any comments, questions, anything that you would like to just kind of put out there. Please place it in the chat box. We will get to it. And if you would also prefer to speak, we would love that. Please raise your hand and we will call on you. Please remember to mute your mics while the speaker is presenting. So today I have the pleasure of introducing Dr. Chris Broda, who has very kindly accepted our invitation to speak at our mechanical support meeting. Dr. Broda has completed his training in pediatrics, pediatric cardiology, and adult congenital heart disease at Baylor College of Medicine. And then he went on to complete an advanced training in ACHD, adult congenital heart disease, heart failure at Toronto General Hospital for about 6 months. His clinical interests involve providing comprehensive care to patients with cardiomyopathies in all forms, as well as congenital heart disease and those patients who may need advanced therapies, such as mechanical circulatory support or organ transplantation. He will be speaking to us today about innovative mechanical support strategies to support the failing Fontan circulation. So, Dr. Broda.
Well, thank you so much for that kind introduction. And I was really honored when you and Mark asked me to present today. It could be the last time you asked me to present, but it should be interesting at least. And so let me see if I can share my screen.
The pressure's on you, Dr. Broda. You got to make it good.
All right. Oh, goodness. All right. So hopefully you can see the full screen here. And I titled this Innovative Mechanical Circulatory Support Strategies to Support the Failing Fontan Circulation. But I also thought about titling it, Is It Crazy? So I wanted everybody to just, this is sort of like hopefully less formal presentation. So feel free to interrupt if you have questions along the way, just let me know. But otherwise, we'll kind of get started. I think I don't have a disclosures slide. I don't have any disclosures, but the objectives for this talk are to discuss the Fontan circulation and Fontan failure, sort of briefly. We'll review the ventricular support options for Fontan patients and potential advanced failure treatment paradigms. We'll investigate potential support strategies for failing Fontan, mechanical support strategies, and then review some subpulmonary circulatory support approaches, which mainly are research approaches for the Fontan circulation. So, we'll talk about Fontan circulation real quick. It was described in 1971, not 1921, and there have been multiple modifications along the way to improve the sort of Fontan circuit, really to maximize efficiency. So we started off with the, sort of like an AP Fontan, this is sort of an older Fontan, not the original Fontan really. And then we now moved on to either lateral tunnel type Fontan or extracardiac conduit type Fontan. These are total cable pulmonary connection type Fontans. And that sort of, we've made the step to improve the Fontan circuit efficiency. However, fundamentally, the Fontan operation bypasses the subpulmonary ventricle, and this leads to obligate overall decreased cardiac output, and increase in systemic venous congestion and hypertension that's needed to pass the blood through the lungs to the vascular bed of the lungs. And so it's currently estimated that probably about 60,000 patients worldwide have the Fontan circulation. And I think this number is expected to double within the next like 20, 30 years. So it's really kind of a good number of patients out there. And in general, we think most patients are, perhaps all patients, are destined to reach a Fontan failure state. And a Fontan failure is a condition in which the Fontan circulation is unable to meet the metabolic demands of the body or effectively drain the systemic venous and or lymphatic circulations. And so there's sort of like ideas about, and there's probably some crossover with these phenotypes, but Dr. Book described these phenotypes for Fontan failure in 2016. I think there's a lot of truth to these phenotypes. And so there's Fontan failure with reduced ejection fraction, Fontan failure with preserved ejection fraction, Fontan failure with normal heart, and then Fontan failure with abnormal lymphatics. So this is a busy slide, but we'll just go over it kind of briefly. Don't want to spend too much time here. But probably Fontan failure with reduced ejection fraction is not entirely dissimilar from sort of heart failure with reduced ejection fraction, in that the systolic function is reduced, the single ventricle end diastolic pressure is elevated, the cardiac output can be low, and the systemic vascular resistance can be high. And so when we think about these patients, these tend to be younger patients, heterotaxy patients, hypoplasts, and along with others, of course. And then we think that, do we think that guideline-directed medical therapy could be helpful? It's certainly not proven in this population. Maybe cardiac rehab, who knows? Fontan failure with preserved ejection fraction, we see pretty frequently in sort of the older population. And in this, we think that the systolic function is normal, but the end diastolic pressure is elevated in these patients, leading to elevated Fontan pressures. And the cardiac output can be normal to low, SVR is typically elevated. And again, these are sort of the older patients that sometimes we see are obese, sedentary, maybe it can happen this phenotype can happen after post-intervention. And for medical therapies, again, limited diuretics, aldosterone, cardiac rehab, who knows if that's helpful. Fontan failure with normal heart has been described, and in these patients, they have sort of like a normal systolic function. Sort of things on the cath look pretty normal, but the patients can often manifest sort of right heart failure symptoms and could be older. And so again, we're limited with medical therapies for these patients. And Fontan failure with abnormal lymphatics, I think probably, especially on the pediatric side, we see this not infrequently. And so here we can have sort of the normal systolic function of the ventricle. The ventricle can have sort of normal to low EDP, and the cardiac output, the reference says could be elevated, but often it is low. And then SVR can be normal to low. And so I think it's not uncommon to see this sometimes in the heterotaxy complex single ventricles, hypoplasts, and it could be other patients as well. And then sort of there's a slew of different medical therapies that we try, but not too many are all that effective. So I think that when we think about Fontan failure, we have to also think about advanced therapies. When we think about advanced therapies, probably the first thing that comes to mind is heart transplant. And to my mind, it seems that heart transplant is a potential therapy for all failing Fontan phenotypes. And there's been sort of a lot written about Fontan transplant. And so this meta-analysis from an AJC in 2017 sort of looked at 12 studies over 350 Fontan patients, and maybe probably a little bit of early era, not too bad. And they ended up looking at these patients who had a mean age of 14 years. And the 1 and 5 year pooled survival was about 80 and 71%. So the prospect of transplanting Fontan at a lot of transplant programs, especially on the adult side, probably not too nobody's going to be eager to do that with a sort of survival with only 80%. Now, is there an era effect? Excuse me. This paper, that was really mostly a pediatric study looking at the PHTS with 150 patients in the early era and 250 patients in the later era, found that there is a survival, sort of an era effect on survival, which is probably not all that surprising. And actually, the Fontan transplant 1 year survival was pretty close to the non-Fontan transplant 1 year survival after the heart transplant. So we're certainly getting better on the pediatric side. Now, I don't know if we have a good grasp on what the perioperative mortality for heart transplant is with adults with failing Fontan. There's a study out looking with the in the NIST looking at it, said it could be as high as 26%, and that's quite high. Hopefully, it's not that high. There are some problems with using that database and stuff. But something we do know is that there's probably about 1,000 transplants excuse me, 1,000 Fontan operations in the US per year. And there's only about 2,000 to 4,000 heart transplants total per year in North America. So, you know, if we feel like most of these patients, if not all these patients, will eventually require a heart transplant, there's just not enough heart transplants to go around. So I think the next thing I think about would be sort of the advances or durable mechanical circulatory support. And then when we're talking about that, we also have to acknowledge some advances in the technology. And so, you know, right now we have this device, the HeartMate 3, available to us. It's a fully maglev system. And I think we're really seeing some you know, using it seems like the patients do quite well on it. The 2-year LVAD outcomes are approaching 2-year heart transplant outcomes. If you look at the most recent update from some of the momentum trial data. And so when we think about if the survival is really approaching sort of heart transplant, which is the gold standard for advanced therapies, maybe we think about what is the strategy we want for these young patients who are maybe in their teens, early 20s, 30s. What's going to give them sort of the best longevity? Because heart transplant, we know, is probably the median or the mean graft survival, which is also patient survival, is probably, you know, between 12 and 15 years. So if we look at the heart transplant journey, from birth to advanced heart failure therapy event, you have sort of a limited time after your heart transplant. But if you look at it in a different paradigm, sort of utilizing VAD's ventricular assist device support, you wonder if you can extend sort of longevity of patients. Certainly, this is not, I don't think, the current paradigm for most programs. And this is a busy slide, but we'll just take it sort of one step at a time. So what could be used for the circulatory system strategies for Fontan failure? And so if we look at it by Fontan failure phenotype, we can also think about using these, using MCS for acute or at the end stage of the Fontan failure presentation, or we could think about using sort of the MCS device for chronic or even potentially prophylactic use. And so sort of a lot of information already. So I just want to see if anybody has any questions. If not, we'll kind of move on. I think when we think about the Fontan support, we think, or at least I think, do we support sort of the single ventricle, sort of left-sided support with sort of a ventricular assist device sort of strategy, or there's been a lot of discussion and thought about doing sort of right-sided support or subpulmonary subpulmonary circulation support in the Fontan circuit. And so we'll sort of break this down as we go along. But let's first talk about sort of Fontan failure with reduced ejection fraction, left-sided support in sort of acute or end-stage presentation. So I think that there are some data for this, and the ventricular assist device therapy and failing Fontans for reduced ejection fraction, FEFREF, if you may, or if you will. I think we have some data to show that for patients, these patients would be those with severely depressed systolic function, significant AV valve regurgitation, may not have ventricular dysfunction, and certainly it's sort of an interesting paradigm, because often when we think of putting LVADs in, we wonder what the right heart looks like, but here there is no right heart. So is it possible really to get worse right heart failure after sort of like an LVAD implant into a patient with Fontan? It's been shown that we can put sort of an LVAD and actually use that to go from Glenn or even to complete the Fontan circulation. And there was recently a multi-institutional study looking at patients who have sort of ventricular assist device therapies. And this study is 45 patients, average age was 10. It's really unclear to me exactly with looking at it, how many adults were in the study, but durable VADs were placed in 33 patients. It was really the strategy was used mainly as a bridge to transplant. There's only 10% of patients were supported for greater than 1 year. We do know that temporary devices can be used to stabilize patients in significant failure and after cardiac intervention. And then with some pediatric and a little bit of adult data from multi-institutional paper, and then sort of some data from combined data from Texas Children's Hospital and Baylor St. Luke's Medical Center. We know that we've used it in a couple adult patients. I used it in PELA-CP on a patient who had acute PE with heart block, and got this patient through with ECOS catheter therapy. And then we also used it as sort of dysfunction after AV valve replacement in a patient. We used a 5.5, Impella 5.5 to support the patient for about 30 days. And eventually he recovered, this patient recovered their function enough to be discharged from the hospital without any support, only medical therapy after AV valve replacement. And we know that the Fontan patients are surviving, more patients are surviving to adulthood. And so it's also helpful to think about what is the durable device therapies available for adults with failing Fontan and reduced ejection fraction. There are some data with this, and there was a look in the INTERMACT registry. This was between dates 2006 and 2015. And in all of INTERMACT's registry between these years, only 17 single ventricles, so we technically don't know if they're Fontans or not, single ventricle patients received therapies. And the breakdown of this was the axial flow devices were used in 12 patients, and centrifugal devices were used in 4, and there was 1 patient who received a total artificial heart. And statistically, there was really sort of no difference between the single ventricle survival in a non-ACHD population, although the curve looks a little less, the p-value was not significant. We can look at what are, again, combined data for adults. What have we seen here? And so technically not a Fontan single ventricle Kawashima patient, heterotaxy, who received, who had some major comorbid conditions that prevented transplant eligibility initially. And so he was, this patient was supported on a HeartMate 2 for not quite a year. There was another patient who was a Fontan patient who also was not a transplant candidate related to polysubstance abuse. He had a HeartMate 2 and he survived for over 3 years and eventually became transplant eligible and received a heart transplant. Another patient, a young patient who ended up not being a heart transplant candidate, received an HVAD and has been supported on this device for over 5 years. There's another patient who, another young patient who ended up receiving an HVAD after heart failure admission. And this patient's been supported for over 2 years. So I think that with these data, we can show that device therapy for failing Fontans with reduced ejection fraction is a viable option for patients. So let's talk about Fontan failure with preserved ejection fraction and that sort of left-sided support. Does this make any sense to do this? Or is it crazy? The potential strategies for support in failing Fontan with preserved ejection fraction, I think that when we think of using mechanical circulatory support for these patients are usually have this problem due to sort of a stiff ventricle, elevated single ventricle end diastolic pressure, which transmits back to elevated Fontan pressures. In general, we don't really like putting a cannula inside a small contractile ventricle because you have a high likelihood of suction events, which leads to device malfunction and thrombotic events. But what if we consider doing atrial cannulation strategy to improve symptoms in a patient who may not be a transplant candidate? And so we thought about this and we actually created sort of a heart failure preserved ejection fraction. This is a biventricular mock loop with Dr. Smith and Dr. Wang at the Texas Heart Institute. So we used a very sophisticated flow loop they had, emulated sort of heart failure with preserved ejection fraction, elevated end diastolic pressures. in the sort of left ventricle portion of the flow loop, and we used an HVAD in a left atrial decompression sort of mode. So the essentially the left atrium was cannulated, and then the outflow graft was essentially went to the aorta. What we found was, so we see the baseline conditions, elevated MAP, elevated LA pressure, and elevated pulmonary pressures. And we were able to decrease the left atrial pressure by 30%, which also decreased the pulmonary pressures as well. Support in this sort of static model increased the mean arterial pressure, as well as increased sort of the systemic flow. It was interesting that both the LV in systolic volume and LV in diastolic volume increased. I think that this model probably was a little suboptimal, as the LVEF actually decreased as we increased afterload to it. So if you if you were to do this strategy with an underlying cardiomyopathy, you might not be able to eject as much. Essentially, is sort of what how I interpret these data. But I guess the point is, with the mechanical assist, you could probably decrease the LA pressure. And so would it make sense to do an atrial cannulation for support of end-stage failing Fontan preserved ejection fraction? Well, let's talk about that a little bit. Atrial cannulation is well described in the Fontan cohort. In that multi-institutional cohort we talked about, over 30% of patients received atrial cannulation strategy. And atrial cannulation strategy has been used for other disease processes. Not very often, but it's happened. I think it was first described at Stanford, where HVAD was connected for a patient with sort of end-stage super burnt out hypertrophic cardiomyopathy with some horrible diastolic dysfunction. This HVAD can be used to essentially decompress the left atrium. And so this is actually data from Canada, where they connected, they used a reinforced graft. They created an ASD, used a reinforced graft through the right atrium, and put the HVAD outside of the right atrium. So it was decompressing, but it was decompressing the left atrium. And so for this patient that was described as this case report, they ended up being able to make this patient transplant eligible with this sort of support strategy. If we translate this over to the Fontan patients, you wonder, in a total cable pulmonary connection, could there potentially be less technical issues in that there's no subpulmonary atrium that the surgeon has to deal with? So I don't know, food for thought. Any questions about that? Okay, we can continue. All right, so let's talk about.
Have you used it, Chris? Sorry, it's Mark here. Have you used it in an animal model yet to do so, or even in human trials?
That's a great question. We haven't done that. I think the animal models for HFpEF, I don't know if they're that well described, but it's definitely something that we should think about doing. I think perhaps if you'd like to write a grant together, we could try to make it happen.
Next time. Okay.
All right, let's talk real quick about Fontan failure preserved ejection fraction with right-sided support. Does this make any sense? Is it crazy? The acute subpulmonary support in Fontan failure with preserved ejection fraction, is it a bad idea? Probably it's not that great of an idea for patients who, for patients who have diastolic dysfunction, high EDP, and high Fontan pressure, to use a device to push blood from the Fontan circuit into a stiff ventricle, but potentially can be used in acute processes that lead to subpulmonary Fontan failure in patients with preserved ejection fraction. So, and the case in point for this is the group in Switzerland described actually quite a while ago now, this patient with tricuspid atresia who underwent Fontan conversion but it developed multi-organ dysfunction. They described in this paper that the CVP was very, very elevated, but the ventricular function was normal. I didn't see a wedge pressure, but that the mitral valve was competent. They ended up taking down the total cable pulmonary connection. They connected the SVC to the IVC with a capacitance chamber. They put the inflow to a Berlin through this capacitance chamber and the outflow to the pulmonary arteries. So using this paradigm as extracorporeal support with the Berlin heart, they were able to decrease the CVP to 8 millimeters of mercury, improve end organ function, discharged from the hospital, and the patient later got a heart transplant after 13 months on this therapy. So that was pretty impressive. So, okay, we can talk about that later. So Fontan failure with abnormal lymphatics, is it a good idea to do support for them? What sort of would the paradigm look like for MCS and Fontan failure with abnormal lymphatics? Right-sided support or left-sided support? I think just briefly to go over it, proper lymphatic function is needed to maintain the homeostasis between the fluid, fat, and protein balance in the plasma and interstitial compartments of our body. Fontan circulation, of course, interrupts these pressure gradients that allow efficient fluid resorption at the capillary and thoracic duct level. I think some patients have abnormal lymphatics to begin with, and when you put the Fontan circulation, they just develop these really terrible problems with their with PLE and plastic bronchitis. Does it make sense to do left-sided support for PLE? There are some data suggest that PLE is most closely correlated with a low cardiac output rather than like a high CVP, for example. So would it make sense to do a left-sided support to increase cardiac output? I don't know, maybe not. There has been a case report actually to look at subpulmonary support to decrease venous congestion and increase cardiac output to resolve PLE. And so this was a paper published not too long ago by a German group. They took a 23-year-old PAIVS total cable pulmonary connection patient who had 7 years of PLE symptoms, was end stage, not a transplant candidate at the time due to I think malnutrition and some other really terrible things. So they ended up doing sort of the same paradigm before, where they took down the total cable pulmonary connection, made a capacitance chamber for the systemic veins, did a Berlin and connected to the pulmonary arteries, and they were able to decrease CVP to sort of really normal, sort of physiologic sort of levels. And this patient appreciated a resolution of PLE symptoms, and this patient improved her nutritional status so much that her endocrine function resumed, and she and so it was really quite an impressive turn. And the patient was bridged to transplant. Unfortunately, this patient didn't have a good outcome after transplant, but the fact remains that, subpulmonary support for lymphatic failure actually actually seemed to work. Okay. So Mark's saying PLE is generally resolving after heart transplants, so wouldn't also bad support for abnormal lymphatics be a good idea? Yeah, so that's sort of I wonder as well. Especially for this, perhaps sort of the right heart failure is resolved after heart transplant. Perhaps that's why. Oh, that I also wanted to show the actual surgical picture. So I think that if you support the right side of the heart, if for some reason you're not a transplant candidate, or we have devices available that are sort of durable and very good, maybe right heart support makes a little bit more sense than left heart support for these patients. And then so let's have a note real quick about temporary subpulmonary support for the failing Fontan circulation. So perhaps it's thought wouldn't be a terrible idea if we had some sort of device or mechanism to do some subpulmonary support, sort of right-sided support for end-stage presentation of Fontan failure normal heart, Fontan failure abnormal lymphatics. It's really, I think the strategy is becoming probably more common recently, taking a strategy for a patient with these phenotypes, and perhaps other phenotypes of failing Fontan, in order to get them through transplant. you hospitalize them and put them in some inotropic support like Milnerno and watch them like a hawk while they're in the hospital, getting them as optimized as possible. So you wonder if there's potential to use some sort of specialized device or specialized cannula to support the subpulmonary circuit and get them to better stage prior to heart transplant. And so there's a group in Toronto that kind of was thinking about this, and they sort of devised a special cannula for temporary subpulmonary support for failing Fontans. And so the cannula was designed with 3 lumens, 2 output lumens essentially, and 1 suction lumen, so input into outputs. And that's sort of the picture right there. And then they used patient-specific anatomy and sort of showed how it would be placed, probably through the IJ, and then you have inflow. It's being sucked through the IVC and SVC into the suction lumen, and then it's being the blood is being ejected through the left and right discharge lumen. And they thought that their CFD studies predicted pressure gains of 4 to 9 millimeters of mercury, and overall their computational fluid dynamic models predicted low hemolysis and acceptable wall shear stresses. So pretty interesting concept. But I think when we talk about subpulmonary support, devices for Fontans, we might be somewhat limited in acute support. But if we if we're able to open up therapies for chronic support, I think that we really have a lot of potential here. Probably temporary support for failing Fontan circulation is desirable when a patient is a transplant candidate. But the holy grail for subpulmonary Fontan assistance is really a durable long-term solution for patients. And it's been thought that even a modest energy input from a subpulmonary assist device that produces a 2 to 6 millimeter mercury pressure gradient may be sufficient to improve symptoms and functional status. So can this be used for Fontan failure with reduced ejection fraction? If a patient already has a sort of a left-sided VAD, would the paradigm be that maybe if they received a right-sided device, could they really normalize their circulation? Because after a Fontan patient receives an LVAD or an LVAD, they still have the Fontan circulation at the end of the day. Fontan failure with preserved ejection fraction, you wonder if you can implement this before they start having diastolic dysfunction of the ventricle. With a normal heart, with patients who present with a bunch of ascites and sort of right heart failure symptoms, I think it makes a lot of sense. And then Fontan failure with abnormal lymphatics, we just saw data that acute support improves PLE symptoms and nutritional status. So one could wonder if you had a chronic device, a device that could be used sort of over a long period of time, maybe you could sort of really decrease symptoms and improve patient longevity. So we thought about this a little bit, and there's no long-term device that exists for patients currently, but there have been a lot of ideas and thoughts about how to actually make this happen for patients. And when you look back at sort of the attempts for this, there's sort of a biological cysts that have been tried and mechanical cysts that have been tried. So we'll talk about the biological cysts real quick. These really date back to the 1980s, 90s, and early 2000s. And this was sort of the time of trying to use skeletal muscle. And folks thought about using latissimus dorsi from the back skeletal muscle to improve, to use a number of ways to treat heart failure. And so there was this report in sort of the late 80s, early 90s that looked at creating a neoventricle from skeletal muscle. So these were animals, and basically a neoventricle was created with valves, and the skeletal muscle was wrapped around this sort of valved conduit. They did electrical stimulation of the muscle. It provided pulsatile flow, but the muscle quickly experienced fatigue, and the experiment was plagued with venous flow obstruction by the valves, and there was a compliance mismatch probably from the muscle and the low pressure circuit needed to sort of, that's sort of more characteristic of venous physiology. And then there was also other experiments that had problems with thrombosis. There was a thought to use so for a patient with an AP Fontan, could you use latissimus dorsi wrap around the atrium? If the original intent was to use the atrial kick to propel blood in the Fontan circulation, could you use skeletal muscle to basically augment this? And so this was a really interesting experiment that was done in animals, and it provided augmented pulmonary pulsatile flow. However, if you look at the experiments, they had they were obstructive to venous inflow. And ultimately, enthusiasm for skeletal muscle waned for treatment of heart failure in general, as there's morbidity using this at all in patients, and then overall the skeletal muscle sort of deteriorated over time with electrical stimulation. It's difficult for the skeletal muscle to keep up with the function that the cardiac muscle needs to. We'll talk about mechanical assists and sort of intravascular devices, and then axial flow devices and centrifugal devices. In general, these seem to be the axial flow devices have been historically the most commonly studied. There's been acute animal models to demonstrate feasibility with this paradigm. And many studies have looked at used computational fluid dynamics and flow circulation loops to sort of have some proof of concept. There's been data to look at, where are actual devices needed? What would make sense for where would they be placed? And having one place in the IVC probably isn't that great, because the blood would be pushed. It would be pushed to the branch PAs in the total cable pulmonary connection, but it would also be pushed into the SVC as well. And so probably that paradigm is not possible. Other axial flow devices have been tested either in animals or in flow loops. And so those include the Jarvik 2000 HeartMate 2 and the Heartware Circulite, which is sort of, I think, like a hybrid sort of device. And then we've also have some data from the group in Atlanta who looked at using a PD-MAG and CentriMag, which are extracorporeal devices, but you could probably theoretically would also be applicable to things like the Heartware or even the HeartMate 3, although those are a little different. And so they found that was pretty interesting using this CentriMag in a way where the inflow cannula to the CentriMag was based at the IVC there at the bottom, and then the outflow graft or cannula was sort of positioned right near the total cable pulmonary connection junction there between the SVC, RPA, and LPA. They showed that using CentriMag, you could decrease the IVC pressure, and then you also induce streaming from the SVC. So the SVC blood streamed into the cannula, which is pretty interesting, inflow cannula. And so so it was sort of a relatively, wouldn't be too surgically complex to accomplish this, I think. Pretty interesting. But I haven't seen any clinical reports with that yet. There are approaches with mechanical assists with catheter-based devices. For lack of a better term, there's some axial flow devices in Pella system. There was an in vitro flow loop experiment that looked at this, and they saw that there was hemodynamic improvement when they used barriers to prevent recirculation with the device. But this particular experiment, the way that they did it, probably you would need two Impellas, sort of like an Impella RP from the neck and probably from the groin, and two barrier devices in order to really get hemodynamic benefit, the kind that you would like for support these patients. And then there was another sort of animal experiment with an Impella where they did an acute sort of atrial pulmonary Fontan type model, and this is a picture of that. And they showed that they were able to support the animal with this device. Usually animals die pretty quickly when you try to create a Fontan circulation in them. But these animals survived if they had an Impella placed and then used a barrier to prevent recirculation. probably these catheter-based devices are more applicable for acute support than they are for chronic support. And then this is a really interesting concept, this von Karman, and I might be saying it wrong, impeller pump. And this is the this is sort of the Rotafeld pump. This is an interesting device using rotating discs to draw fluid in from the Y direction, from the SVC and the IVC, and then radially accelerate the fluid in the x-axis or to the LP and RPA. And so there's been some computational studies and flow loop studies showing that when the device is stopped, there's no power to it, it doesn't move. There's actually a reduction or no power loss when it's stationary. So if it were to have a problem, it wouldn't cause circuit obstruction. And then this device has been in flow loops has shown that it can generate 6 to 14 millimeter pressure rise, and also increase overall sort of output from the system in a flow loop. So far though, this device, at least from the data I've seen, has only been tested with modeling and in flow loops, but certainly I think promising. There's also mechanical assists where people have thought about doing extravascular devices. And so we'll kind of go over those briefly. There was a report from a UCLA group that sort of used the C-pulse, which was sort of like, basically think of an intra-aortic balloon pump, but on the outside of the aorta instead of inside the aorta. So that was the C-pulse device. So basically it was a inflatable balloon that was placed outside of sort of this valve extracardiac conduit in a in vitro Fontan loop. So not an animal experiment, in an in vitro loop. And this report suggested that having the valve conduit and the balloon on the outside of the conduit provided pulsatile flow and increased pulmonary blood flow. They did, in their data, they suggested that the IVC pressure was required to do this was on the higher side. There's a group from, this was a pretty interesting attempt or thought for subpulmonary support. There's a group from Japan that use shape memory alloy. So what they did, if you take shape memory alloy and you make a ring of it and you apply electricity to it, it will actually sort of like decrease in diameter. And so the thought was using like multiple of these along the extracardiac conduit to sort of make a peristaltic-like sort of assist mechanism to improve Fontan hemodynamics. And so they did multiple rings on the extracardiac conduit in a very simple loop, and showed that they were able to create a pulse pressure if they timed the contraction of the rings in an appropriate manner. But overall, there was not really much hemodynamic change at all, just pulsatile flow. So that seems probably less likely to be beneficial. But there are drawbacks to mechanical circulatory assists, and the need for anticoagulation for intravascular devices. Infection risk for both type of intravascular devices probably might have a higher infection risk. Intravascular devices have the problem with hemolysis, and then these mechanical things sort of need a external power supply. So any questions so far? Okay, now you can ask if it's crazy or not. What if we thought about developing a bioengineered pump or something we could do totally tissue engineered for subpulmonary Fontan circulatory systems? And what would be the benefits of this? I think, there was a lot of enthusiasm for tissue engineered things. And the reason for that was because there's the devices could be long-term, biocompatible, less thrombogenic and infection resistant, and theoretically could have growth potential, which could be really interesting for pediatric patients in general. And it might be not that crazy because tissue engineering technologies have already been applied to patients with Fontan circulation. They've been used for extracardiac conduits. And then it's also been thought to use, perhaps we could leverage tissue engineering technologies to make a contractile extracardiac Fontan tunnel for subpulmonary support. So people have written about that and have done some preliminary experiments. So working with a lot of folks at Texas Heart Institute, as well as Dr. Adachi, we sort of wanted to think about this and see if this could be something that we could bring to patients to help them. So we aimed to create a bioengineered pump, at least as a first step, sort of proof of concept. We aimed to create this functional bioengineered pump prototype, and we combined sort of established tissue engineering techniques and some commercially available components, and evaluated the device in an in vitro hemodynamic model. So the way it sort of breaks down is that we create a sort of a biological reservoir prepared from decellularized tissue, and then we use that reservoir to construct the pump, and we'll talk about the pump in just a moment. And then we evaluated this pump in a simple flow loop that sort of looked a little bit like subpulmonary Fontan circulation. To create the biological reservoir, we used decellularized tissues. So we made extracellular matrix. We took porcine urinary bladders, surgically delaminated the connective tissue and submucosa. We took the submucosa and did serial sort of washes to get all the cells off with very little residual DNA content on it. And then we took the biological reservoir and we took the matrix and we wanted to make it to the reservoir. So to sort of have a more mechanically robust system, we took 2 layers of the matrix and put them on top of each other, and we laminated them using the vacuum. That made a sort of a more sort of robust material to work with, and using that, we created this tubular design for this biological reservoir. We did show that the urinary bladder matrix is compatible with human endothelial cells. We used human umbilical vein endothelial cells, and we just cultured them on. It's not pretty standard techniques, and we showed that sort of they retained their phenotypic sort of traits. And then we use the biological reservoir to create this bioengineered pump. So the pump contains the reservoir portion, as well as an inlet and outlet valve, and then the compression mechanism. Sort of like theoretically it could be a muscle, but because that doesn't exist, we used a balloon. So we used a balloon to compress the reservoir to sort of turn the reservoir on or have a sort of a systolic portion, and then we deflated the balloon to turn the reservoir off, the mechanism off, or sort of have a diastolic phase. Next, we evaluated the bioengineered pump in a simple flow loop, and we constructed a simple flow loop using 2 compliance chambers. It was very simple. We just used sort of like systemic veins, and here we said IVC, and then pulmonary artery, and just one sort of tube for that. We used an axial flow pump to create flow within the circuit. And then we simulated blood with viscous glycerin water solution. We used pressure transducers and flow meters to get our data. We sort of set a baseline conditions of flow of 4 and a filling pressure of 6 millimeters of mercury. What are the results of our experiment? We saw that a non-active bioengineered pump really didn't decrease flow that much at all. Overall flow in the circuit was decreased from 4 liters per minute to 3.9 liters per minute. So really not that obstructive and like sort of the off position. And then the pressure drop was less than 1 millimeter of mercury across the device. Looking at this graph, you can see pressure on the left, flow on the right, and then time is at the bottom. The left y-axis, the left or the right y-axis, and the x-axis, the bottom is time. And then the flow is the dotted red, the IVC pressure is the black, and the PA pressure is the blue. So when we sort of turn the bioengineered pump on at 60 cycles per minute or 60 compressions per minute, we saw that we were able to generate overall pulsatile pulmonary flow there's a pulse pressure of like probably about 1 to 2 millimeters of mercury here. And then we were also able to maintain IVC pressures down at 6 millimeters of mercury and increase pulmonary pressure. So we were able to create a pressure gradient between the IVC and pulmonary artery, which is, sort of what the goal of the right ventricle is, I think. And then overall, our flows were maintained at about 4 liters per minute. So that was sort of the end of our proof of concept study. I think that sort of the points are that we feel like we were able to show that we were able to combine biological reservoir with valves and external compression device to create a biological pump, and we were able to sort of have a proof of concept that we were able to create a pressure gradient and a low pressure circuit. But we have some further steps to do, and the proof of concept study sort of like might be promising for in the future. But I think that we have significant limitations in engineering dense tissues and solid organs. So I think that might be the holdup as far as the sort of the biological portion of the force generating mechanism. So to wrap it all up, how close are we for support strategies for the failing Fontan patient? Well, I think for Fontan failure with reduced ejection fraction, acute and left-sided support, I think that's, or like ventricular support, I'm just call it left-sided. I think that's a green. I know there's still some debate over it, but I feel like that's here to stay, and probably will continue to do this in the future for the patients who need it. I think the Fontan failure with preserved ejection fraction, sort of the atrial cannulation support strategy, is curious. I wonder if this would be something that would be possible to do in a patient who didn't have transplant options but was very symptomatic. I think it deserves some more thought. I think for the Fontan failure, the normal heart right-sided support and the abnormal lymphatics, I think that it's sort of been shown that it's possible to do, but taking down the total cable pulmonary connection and doing an extracorporeal device is, sort of going to be difficult to sort of translate widely. And I think I just don't know if that's something we recommend for all patients. I think for chronic and prophylactic use for VADs, I think the concept makes sense. And I think maybe one of the limitations is the available technology. So, as we advance with our sort of technological advances, one wonders if this was going to be sort of the paradigm for patients who have single ventricle heart disease in the future. All right, so that was a lot. You can tell me if any of that was crazy or all of it was crazy. I'm happy for any feedback at all.
Thanks so much, Chris. That was not crazy, but very interesting. We loved all the concepts and the innovative things that you brought forward. I did have one question for you. Have you seen in your experience in your training that you've done in the adults, has anyone used the viscous impeller pumps at all, or is that just all very investigational right now?
I have not. You mean for Fontan patients and stuff?
Yeah, for Fontan patients.
I haven't seen. So really the most mechanical support I've seen is sort of the stuff that we've done here, I think, actually. So I haven't necessarily seen anything else done like that. And then the only other reported ones that I could find in literature, sort of for more sort of creative support paradigms, have been those extracorporeal Berlins. So that's about it.
Yeah, because the von Karman mode, because I saw that paper as well, is very intriguing in the concept of how it actually works. And it was brought forward actually in the early 2000s as well, that concept. So it's just kind of fascinating that it hasn't yet been successful. And the device that you guys are engineering or working on currently, is that something that's more external to the vessel and then you kind of just connect the two ends?
So that one, I think that one is really interesting. I do have, you usually don't want to be sort of negative about your own research, but I think that the tissue engineering sort of to actually get therapies to patients for sort of dense tissues is difficult to do. So I don't know if the technology is going to be there in 5 or 10 years, or who knows when it'll be. But sort of the support structure would be potentially you could do 2 different ways, I think, with that sort of model. You could do sort of like recreate maybe like a 1.5 ventricle type physiology where you have the IVC to the inflow of the device, and then the outflow is to like the pulmonary arteries and the SVC, sort of like 1.5 with a Glenn sort of type thing. Or you can do maybe more sophisticated surgical implantation where you have both the IVC and the SVC going to the inflow of it, and then the outflow goes to both pulmonary arteries. And in that sort of way, if the device were to fail and the off position was sort of in diastole or with the valves open, with those preliminary data, hopefully it wouldn't be too obstructive. You would just kind of revert more back to a Fontan circuit sort of physiology. But if it were activated, perhaps you could use it to create a pressure gradient and maintain flows.
Awesome. Does anyone from the audience have any questions or comments for Dr. Broda? Thoughts? Praises? Oh, Antonia, you have your hand raised.
Yes.
Go ahead.
Hi, Antonio Corno. I have, first of all, congratulations for a very brilliant presentation. I learned a lot. Very well done. I have two quick questions. The first is, among the buffet of all the potential mechanical assistance that you presented, the most, or at least attractive, are the one of Rodefer and von Karman, but they require a situation where there is no offset of the superior and inferior vena cava connection to the pulmonary artery. Over the years, we learned at the moment of performance of a Fontan procedure, to leave the max possible offset between the SVC and the IVC, because we learned from computational fluid dynamic studies different. Then if you leave enough offset, you decrease the energy loss, therefore you facilitate the flow to the pulmonary circulation and so forth. So based on your observation, should we change now and go back to do the Fontan without any offset? Because in the future, this patient could have a Fontan failure, and this could be a good modality of assistance.
Dr. Gordon, I'm very honored for your question and that you're joining this talk. Thank you very much for that. I think that's a really good, a wonderful question, and hopefully I'll have an adequate answer. I wonder if, because I think that some of the early Rodefeld work mentioned, kind of thought that maybe they would do a transcatheter sort of assist and they'd put it in with a catheter and leave it on the catheter. I don't know if they're evolving more toward sort of a more surgical paradigm. So I wonder if they were to implant have the device suspended in a graft, perhaps, and then the graft would be attached to the SVC, the IVC be attached to the graft, and the branch PA is attached to the graft with the device already suspended in it. I wonder if that would make more sense, because I totally agree with your point about, doing the offset of the IVC and SVC. I think there was some really elegant work out of Georgia Tech to show the fluid losses and all that stuff. And so, so for me, I think that probably, again, it's hard for me to really answer probably to your satisfaction, but I think probably I wouldn't change the way the Fontan's done now. And if there is this sort of quote fourth stage of Fontan, it seems like it might be probably requires another surgery, unfortunately, but probably that's probably what will end up being if we get to that point.
Thank you. That makes a lot of sense. The second question is a bit more complicated. You have clearly shown that we don't have yet any modality of mechanical assistance for the medium-long term. Therefore, is there any situation where you, instead of going immediately for a mechanical assistance for early treatment, in the presence of Fontan failing with one of the various modalities, do you consider surgical alternative, like taking down the Fontan, start a program to try to recruit a biventricular circulation when the morphology allows so, knowing then the long-term or medium-term result of mechanical assistance is grim and heart transplant is very rarely available?
Yes, thank you again for the question. And like you said, sort of a difficult paradigm for patients. I think that, the enthusiasm for Fontan conversion to make the Fontan circuit more efficient think we're much more enthusiastic for patients who have like an AP Fontan who are young. But if you have an older Fontan who's having problems and they're AP and they're still, they don't have a total cable pulmonary connection, they're inefficient, but they already have a lot of Fontan sequelae. Maybe it doesn't make that much sense to try to do a Fontan conversion at that point. And so I suppose that could also be if the patient has an underlying cardiac anatomy that might be suitable for a potential biventricular repair. That seems like it could be enticing, but I think sometimes the patients end up as a Fontan for a reason, and then trying to go back for a biventricular repair, you might acutely have some discharge from the hospital and stuff, but I don't know how long or how durable those biventricular repairs are for those patients who have an underlying substrate of sort of not a great heart. So again, I don't know if that's a really answers your question to that well, but just sort of my thoughts on that.
Thank you. I hope in a few years we can give you some more information about the biventricular reconversion after Fontan. Thank you so much and congratulations again.
Yes, sir. Thank you.
Thank you, Dr. Broda. Excellent talk, and thank you for all the education. We hope to see you back again with one of your engineers and have a very different discussion.
Thank you so much. It was wonderful. I really appreciate the opportunity. Thank you so much.
Absolutely. Have a
Thank
good
you,
one.
Chris. Really great. Thank you. Much appreciated.
Thank you.